Hi, it's Matthew Holt. I'm here for yet another THCV Spotlight, and this one is with Will Boeglin. Will is the CEO and founder of TimeDoc Health, who I honestly hadn't heard much about until relatively recently when they raised a pretty decent sized round in the old 48 million wandered in the door. So I thought we'd better meet Will and find out what it was all about and what they're doing. So Will, TimeDoc is in the world of helping clinicians and clinics and healthcare and health systems with chronic care management and remote patient monitoring. We've heard a lot about these terms, and we're actually going to see what that actually means in the course of this demo. But just give me a little background on the company, the history, how you got into this, and where it's come from.
Yeah, absolutely. Thank you, Matthew. So I would just start off on kind of a high level and say that what we do now really all boils down to one thing, which is time, and that's why that's in our name, because we make it easier for overstretched providers who don't have time to manage their patients with chronic diseases in between visits. And we do that by combining the right technology platform with the right care coordinators to help them run these programs at scale, manage the programs, and be effective. But we started off as really just a software vendor that was trying to address the challenges inherent with running a chronic care management program. After Medicare came out with the program in 2015, my co-founder, who was a medical student at the University of Chicago, kind of had the initial idea for a software platform called TimeDoc that would help providers start this program and manage all the documentation requirements that go along with capturing the minutes spent on chronic care management, on all those care coordination activities, and actually creating care plans and billing insurance to get reimbursed for this type of work that they could finally get paid for. But over the course of the first couple of years, we tried to implement these programs at practices across the country and had some success with some of the early adopters who were a little bit more progressive, and then pretty quickly ran into challenges of staffing shortages, the fact that a lot of primary care practices haven't had the opportunity to really start, virtual CCM programs, and now more recently RPM programs. And so we built out the kind of services component of our business, and we're pretty passionate today about the combination of technology and people in care actually helping with the clinical piece of things. And so we've scaled up that side of our business, and we're one of the few vendors in the CCM and RPM space that offer a truly comprehensive people, process, and technology offering, and with RPM devices as well. And we think that the combination of all those things is really what drives value. And we've scaled that up over the past 7 years. We're now servicing over 120 unique healthcare organizations, and that represents over 70,000 actively enrolled patients across the CCM and RPM program today.
So excellent. So you had some success. You've got sort of off the dime and added another of those clinics. You mentioned that. So are there customers you have out there who just use the technology and are managing it themselves? Yes. Or is pretty much everyone used, what's the ratio between the people using your services, your care coordinators, and your clinical staff as well? What's the rough ratio?
We do have folks who are just using the software. We have 3 different models. We have the just do it yourself model using the technology. We still provide quite a bit of support services to help train staff and, share best practices kind of in an advisory way for those clients. Then we have the fully outsourced offering where they outsource to our care coordination team. And then we have a hybrid kind of mixture of the two, which is a very popular model. I would say that about half of our client base uses the software on their own. And then 40% is in that kind of hybrid model, and the last 10% is fully outsourced.
I see. So there's a fair amount of activity going on from the clinics themselves. And then this is an area, I know certainly CCM, RPM has grown tremendously in recent years. And I know that those codes came a little bit later. The CCM code, there was one company, which is CareSync, which had a big flame out. So there was some conversation at that time as to whether it was because the CCM model itself with the codes and trying to get patients on board, and apparently there were some issues with copays was the problem, or was the or were they the problem? In other words, is CCM, you're seeing CCM as a viable business for companies like yours?
Oh, absolutely it is. I think it's challenging to scale because you really do need to build out a very robust tech platform and services component. You need to be very proficient with the way you operate in the business. So it's not easy to scale, but with the right kind of operators in place and the right tech, underlying the operation, it's a great business model. So I think, some of the early movers struggled. They scaled incredibly fast before they had some of the foundations in place.
So this is an execution challenge, not a business model challenge, as far as you can. And then in the business model, I understand, and I made the numbers right for RPM and CCM. There's, is it what, $50-ish per month for each one of those per patient who qualifies? Is something like that? And if that's about right, and roughly how many patients per doctor qualify?
Yeah, roughly $60 of reimbursement for CCM per patient per month. RPM is split across a few different billing codes. There are two that are roughly $50 each. One that pays for the actual usage of the device, and then the other that pays for 20 minutes of clinical staff time monitoring the biometric data that comes from the device and coordinating care as appropriate.
So what I'd like to do now is you actually show me how that works, right? So if you show up in the as a clinic or whatever, and I have installed TimeDoc, and now I have to have a bunch of patients out there I have to manage because I have to show the CMS or do any private payers pay for this? Or is it all CMS?
There are some private payers. It's rare. It didn't pick up quite as much as.
But it's mostly I have to justify to Medicare what I'm doing to bill this on a fee-for-service basis. So why don't you show me how I would use TimeDoc as a clinic or as part of your services to actually do that?
Absolutely. 1 second here as I pull it up.
You can hit the share button and away we can go.
Got the share button. Let me know when you can see it.
Yeah, we're all good.
All right. So EHR systems are pretty ill-equipped for care management. They're working on it, but it's an entirely different suite of functionality that you need to kind of monitor patients remotely. The way you document encounters is fundamentally different. These programs require an element of time tracking. So we started off with a minimum viable product that was around care planning and time tracking and billing, and really expanded into a full-blown virtual care management platform that combines functionality for the CCM program, remote patient monitoring with integration with devices, behavioral health integration as well. We do a decent amount of that. And one thing that's very important to note, it's always been one of our core principles as we've designed the software, is that busy clinicians are not going to log into a separate application. So we've worked really hard on integrating the software with the most common EHR systems, and we integrate with all the major ambulatory EHRs. And we found really creative, innovative ways to kind of overlay our application with EHRs so that those busy clinicians can still operate within the EHR. But for a care manager who's got a panel of patients, it makes sense to come into the TimeDoc application to manage those patients directly, because we have so much robust functionality around managing that panel of patients. That's the kind of user persona I'm going to focus on showing this demo, is a care manager who has a panel of patients. So when they're in the TimeDoc system, they can see their panel of patients in this patients list view. You can see how many patients are dedicated to you specifically. So if I go to a particular care manager's name, you would click on a care manager here, and it would just pull up the patients within their panel, and you can see information from the EHR system. Actually, we pull all this in real time from the EHRs that we support. But you've got the patient's name, their age, their gender, which programs they're enrolled in. So patients can be enrolled in CCM and RPM or just one of those. You've got the name of their billing provider. So this is typically the primary care provider who the patient sees on an ongoing basis, and whom the patient is enrolled underneath for these programs. We pull over their active problems. We just display 2 here, but we pull over all those diagnoses from the EHR, and it's always kind of kept fresh as those things change. And we're able to calculate a risk score based on data within the EHR system. So it's a kind of a version of the HCC risk score that looks at diagnoses, age, gender, and enables you to kind of sort highest to lowest, or however you want to sort that, to try to figure out which patients you might be reaching out to. Then, of course, we have the number of minutes spent on the various different billable programs, CCM, RPM, and BHI. So you can do time tracking, and you can sort and filter based on minutes here.
So and on the minutes side, you have to do 20 minutes for each per month to keep them in the program. Is that right? Or what's
not to keep them in the program. If you're going to bill the CCM, RPM, or BHI codes, you have to reach that 20-minute threshold. Somewhat of an arbitrary number that Medicare put out there, but that's how the reimbursement works for these fee-for-service codes. The patient can still be in the program for months, even if they aren't receiving services. And typically, what we recommend is you come up with kind of a cadence for each patient that fits their needs. So some patients might not need to be engaged every single month if they have their conditions, relatively under control. Maybe a quarterly cadence is most appropriate. For some patients, a monthly cadence is needed, but you have that flexibility. This just enables you to see how many minutes have accrued in any given month to date. And one thing to note here is that for a lot of our clients, where we're providing services through our care coordination staff, and the clinical staff at the practice are also providing services, often for the same patients, you can see total time accrued across all clinical staff, across the whole patient's care team. And that's important because it really is usually a collaborative effort between the entire care team. So you can see those minutes aggregated here.
So if they're not using if a patient goes without a month with no minutes, they're not getting paid for that month. Is that correct? Or is something getting paid?
You wouldn't bill insurance for those services that month.
Okay.
The patient wouldn't be charged. The provider wouldn't get reimbursed, and that's fine if the services weren't necessary or appropriate.
And can you bump it within the CCM or the RPM if you do more than, if it required 40 minutes? Can they bill more at some point, or is it just a flat fee for getting up to 20? Is that a cliff?
Today, for independent providers, not for federally qualified health centers and rural health clinics, but for your independent clinics, there are codes that pay for increments of 20 minutes over the initial 20 each month. So you can pay for up to 60.
So recording the number more than 20 actually is important to see that number done between your team, their team, or whomever else. So that makes sense. Great.
Correct.
So why don't we go look at a patient and see what the actual workflow looks like?
Absolutely. So let me pull up a patient here. It's a test patient that we have. Obviously, all this data is dummy data.
Surprised you don't want to do a big HIPAA violation right on here, but it's fair enough.
Yeah.
You were
Broadcast that, right. So this is a patient's chart inside TimeDoc, and it's preceded with a lot of data from the EHR system. Again, we have kind of evergreen connections with the EHR. The EHR is the record of truth when it comes to their diagnoses and their medications. We pull all that data over into TimeDoc, but this is really structured to help a care manager who has a panel of patients stay organized and provide the kind of right outreach and intervention to their patients at the right time. So care managers can schedule follow-ups for patients and manage those follow-ups here. You can see all the encounter notes from phone encounters that the care managers had historically with the patient here. And when you're going to engage the patient to have a new encounter as a care manager, you can slide open this view that we call the care module view. We have a whole host of different modules, like questionnaires that you'll go through the patient, depending on what conditions they have, depending on what kind of screenings they need. So for in a CCM program, typically you're doing things like fall risk assessments and depression screenings. Effectively, the whole health risk assessment that you would do as a part of an annual wellness visit to kind of identify the patient's, barriers to receiving care, to help establish health goals that they're working towards, to uncover health risk behaviors, and try to create a plan of care that you can then implement over the course of a year or multiple years while the patient's in the program.
So if you were to open one of these, you would show the questionnaire or the questions that the way that it gets recorded by the care coordinator.
Exactly. You've got just a standard PHQ-9 here.
Right. I see.
That you'll fill out, and it scores itself. So at the end of the encounter, it'll actually produce the score and a report that can go directly into the patient's chart in the EHR, so that the provider can see it. Our system's smart enough as well to, if the patient has it's indicated that they have severe depression here, it will recommend doing a suicide risk assessment if appropriate. So there's some logic behind the scenes that helps recommend going from one type of assessment to the next to the care coordinator. Depending on what diagnoses the patient has, certain disease-specific modules will pop up, like the COPD module here. It's a whole series of questions. And the point is to capture structured information on these patients on an ongoing basis. So we've got a whole host of these kinds of modules that folks go through. And from a billing perspective, there's a running clock. The clock doesn't automatically document itself. You still type in the minutes that you spend, but it helps you keep track of how long you've been working on behalf of the patient for compliance reasons. You need to document them accurately.
Right.
And then you can do that here. And you can kind of tag the encounter with hundreds of different kind of tags here that indicate what was completed during the call, particular results that might have been achieved. We have a patient success story flag that is commonly used by folks when they feel like they really had a meaningful impact for the patient. We report on those, we celebrate those as a business, as do our clients, and then just a basic notes section, and then you can create a follow-up here. You can link care plan notes and then save off encounters that way. It's all designed around trying to make an efficient care manager workflow.
All right. So there's obviously a conversation going on the phone with the patient while this is going on. You're recording this information, and it's going, and then this goes to multiple places, right? So one of these is it's going. You said you're putting this back into the chart. So how does it go back into the chart? Does it go back to the CCD, or how does that work?
No, it typically is a PDF document that we put in the patient's chart. We can work with the practice on where they want that to go, but we put that in the chart as a PDF document.
And then the other part of it is now they want to get paid for that 20-minute encounter or whatever. What happens next at that point?
So the software, and this is one of the things we see practices struggle with the most, who are trying to run a CCM program on their own, trying to keep track of the minutes and figure out, based on billing requirements, which codes they can bill, can be an incredibly manual intensive effort that takes hours and hours and hours from some of their billing staff each month. Our software is smart enough. It understands all the billing requirements across the various CCM, RPM, and DHI codes. And it can identify the patients who are eligible for those codes and kind of recommend which codes the practice could bill for. So it doesn't bill automatically itself, but it's showing the practice, hey, these patients have met the requirements for 99490 plus 99487, et cetera. And this is a view that shows you what codes we're recommending here based on what's been documented.
And how do they actually get that into the billing cycle? Is there a separate way that it integrates into the revenue collection?
Correct. Yeah. We have the ability to push what we call like pending charges, to create pending charges in the practice management EHR system. It actually pushes some of that data you need to populate a claim. It doesn't actually complete the billing process, but what it does is it prevents the billers and coders from having to manually type in all the various data points, diagnosis codes, billing provider, patient information, date of service, so that more or less the billers are just going in and reviewing that information.
Yep.
And then posting from their system. It saves them about 5 minutes per claim per month.
Which is real time, especially when you're doing this many. And so that's I think. So then, and let's quickly look at the RPM version of this. And if it's
absolutely,
because this program, I mean, it's obviously somewhat more controversial. And there's some other parts of this because now you don't just get a call on the phone; you actually have to get them stuff to their house. So yeah. When you come to a clinic and say, okay, we're going to run your RPM program for blood pressure or whatever the thing is, give me a sense about how that works.
Yeah, absolutely. And we're pretty passionate about the value and synergy you get when you combine CCM and RPM together. They shouldn't be separate point solutions. They shouldn't be entirely separate programs. It's generally the same patients who can benefit from coordination of care as those who can benefit from having a blood pressure monitor, reviewing their blood pressure data, titrating their medications. So we have it all in one platform. And again, a lot of times the same patients are enrolled in both programs. You have to onboard the patient into RPM. We have cellular enabled devices that are incredibly easy to use. They don't require a smartphone or that the patient has Wi-Fi. They're just one click of a button and the data shoots up directly into our application. And then for most EHRs that we work with now, we're also able to put those discrete data points into the vital section of the EHR. But you can enroll the patient into RPM here, and then you can associate a device with the patient, which is something we do automatically. We ship it directly to their home. If we're providing services, we call the patient when it arrives, walk them through the process of taking it out of the box and testing it for the first time. And we do a confirmation test. So we see the data flow into TimeDoc for that patient. And if I come into the RPM work list here, you can see patients who are enrolled in the program. You can see the date of the last RPM encounter, and then readings from the devices that the patient's using. So for this particular patient, there have been 8 new blood pressure readings. There have been 38 new glucose readings. And in the month of May, there have been 12 total unique days with readings submitted.
And by the way, are almost all the devices either blood glucose meters or blood pressure? Is there other stuff?
That's what providers are predominantly choosing to start with.
Right.
In particular, I would say blood pressure is the most common starting point.
Yep.
But between blood pressure and blood glucose, yeah, those are the two use cases that folks are predominantly beginning with. But it's nice because you can see 30-day averages for systolic and diastolic readings, the percentage and number that were in target. And in our application, you can set the actual parameters for kind of what's like within range and what's outside of the healthy range for any given patient. You can customize it on a patient level, not just kind of on a whole population of patient level. That's important because the American Heart Association has really helpful guidelines for what should be considered kind of high blood pressure versus not. But when you're actually managing patients on an ongoing basis, what would be considered like a out of range reading, needs to be customized. Providers typically want to customize that, so you can do that here. And our software will actually send out email alerts when the patient has an out of range reading to whoever subscribes to receive those. But you can see that information here for every patient. And then the idea is actually take action on the patients who have out of range readings and need some type of intervention.
And in terms of the so looking at, I don't know how much more detail there is on the individual patient level you want to show us perhaps, but in terms of the actual taking action, and then again, sort of going back to the question about how do you get paid for this? What happens? There are different codes. Is there a code for the equipment and a code for doing something about it? Essentially,
Right.
and what happens if somebody's out of range and needs more training or coaching to get back in? How does that play with the CCM intervention?
Yeah. So Medicare did recognize that, a big part of the cost required to run an RPM program is the actual hardware, the device itself, in addition to the staff you need to hire to monitor that data. So there's a code 99454 that pays for a meaningful usage of a device. Medicare defines meaningful usage as if the patient submitted readings 16 days out of any 30-day period. And our software is able to track that, just keep track of how many unique days the patients use the device within a 30-day period and suggest billing that code. And then there's the 20 minutes of monitoring code as well. So your question was, if a patient does have an out of range reading, what's the kind of intervention look like from there? Is that right?
Yeah.
Okay. It's certainly going to depend on the particular patient, but a typical workflow involves reaching out to the patient via phone, asking them to take another reading to kind of confirm the first one. And then if it is truly, indicative of a out of range reading, then following whatever protocol the provider has established. So the provider usually establishes kind of standing protocols for what you do if the patient has an out of range reading for hypertension or diabetes, and kind of executing on that from there. But within the software, you can do hypertension specific assessments or diabetes specific assessments to get more information about what they've eaten, or medication adherence. So we have a whole module around medication adherence reviews that's really important to do kind of in conjunction with the RPM and CCM program.
And dumb question, but if they're calling most of this activity, is this happening behind the scenes, or do they have to be on the phone with the patient while this is going on? And if so, how do you make that connection?
Well, for the assessments, yeah, you need to be on the phone with the patient to complete those, to gather that information from patients.
And dumb question, where's the phone number in this? It's somewhere in
the phone number is over in I don't think it's displayed for this patient. Usually there's a contact information section over here.
But people are calling out of it, but people in general calling out of a separate phone system. They're calling.
Yeah, people are calling out of a separate. Okay, here's the contact information.
Right.
So they have multiple. We'll list, every phone number the patient has.
Yeah.
We pull over the data from the EHR system, and we can get it from patients as well.
But in general, the workflow is they're calling on the phone. They're sitting at the co-coordinator is sitting at their desk, going through this stuff. And if it's an outbound phone call and they're actually working with the patient, they'll be documenting that in the time later.
Correct. And we're starting to send text, like secure messages out as well to patients to, remind them to use their blood pressure cuff, to congratulate them for using their blood pressure cuff, that type of thing. So it's some interactions we're finding are more efficient or more effective to be done via SMS, and some require that kind of live interaction. So going about it that way.
But do they have to be on the phone with them to bill the 20 minutes, or is working in the background around medication adherence and that stuff, does that count as well in terms of the billing?
You do have to have a live interaction with the patient to actually bill the 20-minute code for our patient.
I see. Okay, that's helpful. And then that's interesting. Are there I don't know if there's any other specific parts with this within the RPM part you want to show me, but perhaps we can. I
think I just went into the other part that's most helpful to see is just all the readings.
Right.
You can change by time. You can set that custom range.
Change the range. I see. Yeah.
Of what's normal. You can see it in graphical format. So just those kinds of views. And then there's reporting that stems out of this. We work with providers to understand how they want to see the data. We're seeing kind of a range in preferences, but most providers want to see averages in a given period of time.
Yeah, I think so.
In order to make decisions about medication therapy management.
And then in terms of getting this back to the doctor, right? So if you have a care coordinator, I mean, at some point they raise this back to the doctor, so it goes back in the record. But I assume there are times when they actually want to alert a clinician and say, okay, this person seems to be having more of a problem, we should do something about it. And others where they can say, hey, don't worry, this person doesn't have to come in for 2 months or whatever.
Yeah, we've got kind of a few different levels of reporting to the provider. So we've got the more urgent alerts that go out automatically if they subscribe to get alerts when a patient's out of range. We have weekly or monthly summaries of data that push PDFs into their system so they can see all the readings within a particular time frame and what the averages were in that time frame. And then we have like the pushing the actual discrete data points into the vital section in the EHR so they can see that data within the EHR too. And even beyond that, we're trying to work with providers to create some reports that identify patients who might need medication titration or just medication therapy management in general. Because what we're finding is providers are just so stretched for time that they, the more actionable you can make the data to kind of point them to the patients that they need to go have an intervention with, the better. There's just not enough time in the day between the patients they see in the office. So trying to really make the RPM data actionable is critical to actually driving, outcomes.
Yeah, I mean, that's great. So we'll just a couple of questions to wrap, and you can stop sharing the screen now, I think. On that point, the idea of this whole program is not just to spend more of the taxpayers' money, it's actually make a difference in patient outcomes. So what are you seeing in terms of the improvement in outcomes and, both for the workflow, but also the outcomes for clinicians? Are they saying, you're hearing back saying, yeah, we're actually making a dent in how these patients are living?
Yeah, we have some pretty exciting data just recently from our RPM program. So we're seeing after 10 weeks of being enrolled in RPM for high blood pressure management, a 22% increase in the percentage of patients whose blood pressure is under control.
Oh, that's fantastic.
Just 10 weeks into the program. And I think that's really promising because I think we've achieved those results with some of the kind of just low-hanging fruit, to be honest. There's still so much more room for improvement in terms of enabling the providers to manage medications and make those decisions. I think just getting the patients the devices, getting them in the habit of using the devices consistently, educating them on condition management around high blood pressure and diabetes, that has a pretty immediate effect within 10 weeks. Then beyond that, I think we can generate even more value in partnership with the provider.
The last question, big picture, you've got, you said you had 70,000 patients on the system.
Yeah.
I assume that's a big increase in recent years because you're only a few years old. A lot of other people are doing RPM, and there's discussion on CCM out there. How penetrated is this market for the patients who need it? I hear that up to 2/3 of Medicare patients apparently could be on one of these programs. Are we sort of scratching the surface? Do we already have, how big do you think this can get, and consequently, how big do you think TimeDoc can get in terms of patients just with the current products you have now?
Yeah, no, I think we're just scratching the surface, to be honest with you, because RPM has been around for a while, but the use cases that providers have focused on with RPM have been fairly narrow and have been kind of more episodic in nature. The patient's discharged from the hospital with a specific condition, maybe congestive heart failure, and they're doing kind of short-term remote patient monitoring to prevent a readmission. This is the first time there's been a reimbursement and payment for kind of more continuous longitudinal monitoring of patients who might not have had that kind of acute event yet, and you're trying to be very preventive. And I think a very small percentage of Medicare patients who could benefit from that use case are in these programs today. So we've just barely scratched the surface. Out of the 50 million Medicare patients, I think the vast majority of them could benefit from still both of these programs. CCM has been around a little longer, but the penetration I still think is pretty low. So going from, our goal, what we're really focused on is going from 70,000 patients to 1 million patients over the next 4 years. But that still, I think, is scratching the surface. Obviously, that's massive growth, but more patients need it. Beyond that, I think we could grow beyond that too. So there's a real opportunity here, and I'm excited to see the impact that can have on the healthcare system when we get there.
Fantastic. The last question was going to be, so what does good look like in 4 years? And you already told me, and a lot of people shy away from that. So we've heard that target here from you, Will. So
yeah.
I've been talking with Will Boeglin. He is the CEO of TimeDoc Health, which is, as you've seen, is now not just thinking about, but actually genuinely in the CCM and RPM space. Will, thanks for your time. Really interested to see what you guys are doing. Congrats on the raise, and good luck with getting to that 1 million patients.
Yeah, thank you so much for having me, Matthew. I appreciate it.